The Amplitude trial was a large phase 3 randomized double-blind placebo-controlled trial of patients with metastatic prostate cancer with alterations in genes involved in homologous recombination repair. About half the patients had an alteration in BRCA2 or BRCA1, and there were 7 other HRR genes that were part of the eligibility criteria that allowed patients to be randomized. In total, we randomized 696 patients to either niraparib and abiraterone or placebo and abiraterone. All patients received continuous ADT. They received prednisone with their treatment. The primary endpoint was rPFS by investigator review. And there are 2 key secondary endpoints: time to symptomatic progression and overall survival. And the statistical analysis plan used a graphical approach with group sequential design to test first the primary endpoint and then each of the 2 key secondary endpoints in populations of interest, which were predefined, starting with BRCA, ending with the whole HRR or ITT population. So the key efficacy endpoint, primary endpoint was met. So the Amplitude trial met its key primary efficacy endpoint with a improvement or reduction in the risk of radiographic progression or death in the BRCA population by 48%, and in the intention to treat population by 37%. That's a hazard ratio of 0.52. In the BRCA mutant population, a hazard ratio of 0.63 in the ITT population, both statistically significant results. In the first key secondary endpoint, time to symptomatic progression, there was a clinically significant and statistically significant benefit of adding niraparib, with a reduction in the risk of symptomatic progression by 56% in the BRCA mutant group, by 50% in the ITT group. And lastly, overall survival. At this first interim analysis, there were about 50% of the deaths that will be needed for the final analysis, so the data is immature. But the direction of the hazard ratio estimate is favoring niraparib, with a hazard ratio in the BRCA M group of 0.75 and the ITT of 0.79. So that is not significant. Now, the rPFS estimate, which was the primary endpoint, that is tracking the benefit with PARP inhibitors plus ARPI in line 1 mCRPC. But with the difference that although the relative benefit is similar at this stage, the absolute benefit is much larger because patients live much longer and are on treatment for much longer, about 4 times as long. So the absolute benefit of using niraparib at the stage of the disease is at least 4 times long. I would hope that we would also have more long-term responders, and it is too early to comment on that at this interim analysis when comparing to the mCRPC trials where we have more mature data. So this is important, and I already said that we used a sequential testing of the endpoints, first in the BRCA population. And the reason why BRCA was singled out, first, is the most common. Over 50% of patients had a alteration in a BRCA gene, but also there is the strongest evidence for sensitization of cancers by loss of BRCA. And the signal there is very strong. In the rest of the 7 HRR genes, the hazard ratio for the primary endpoint in the non-BRCA HRR population is 0.81. So, and when we, in an exploratory underpowered, so not pre-powered analysis of rPFS and the other endpoints by each individual gene subgroup, we see heterogeneity of effect. So there's some signal of sensitization with some genes, but not all. The individual gene subgroups are too small to confirm which definite to confirm with certainty levels of efficacy across that group. And that really is going to require larger other trials, and then probably approaches such as meta-analysis approaches that include patients with different gene alterations from across trials. So there's a signal in the non-BRCA, it's weaker, and I interpret the subgroup, the exploratory subgroup analysis, as the effect being heterogeneous across that group. Yes, so there were more grade 3 or 4 toxicities in the Niraparib group, 75% with Niraparib versus 59% with placebo, so 16% more. So you asked about treatment discontinuation, and this is somewhat reassuring. So the percentage of patients who discontinued treatment because of a treatment emergent AE was 10% in the placebo group, just over 10%, just under 15% in the Niraparib group. So just under 5% of patients have discontinued because of toxicity. In terms of the side effects we observed, and you've specifically asked about hematological toxicities, the systems involved are the same as in the CRPC trials, so primarily hematological toxicities and second cardiovascular. Anemia was the most common overall grade 3 or 4 toxicity. The majority were grade 3. So 99 grade 3, 2 grade 4. So that was 29% of patients with Niraparib had a grade 3 or 4 toxicity. We also had one case of myelodysplastic syndrome in the Niraparib group. That was in a patient who had a CHEK2 germline mutation. And we had 14 deaths with Niraparib versus 7 with placebo. I see this approach being integrated in a biomarker-selected population, both to maximize benefit and to minimize unnecessary toxicity. The Amplitude trial mandated continuous ADT and mandated continuous ARPI. And the trial was Abiraterone plus Pred, because prior investigations observed drug-drug interactions with AR antagonists and PARP inhibitors, and Abiraterone was the one that could be most safely administered. The Amplitude trial also allowed prior docetaxel, and 16% of patients received docetaxel, and there was no difference in the efficacy in a pre-specified subgroup analysis by prior docetaxel. So what I would expect, or the way my practice will change when the label for PARP inhibitors, specifically Niraparib, here is extended to this disease state, is that all patients will have genomic testing at diagnosis with metastatic disease as a reflex test. Those patients who have a BRCA alteration or potentially an alteration in one of the other eligible 7 HRR genes will have a discussion on the benefit at this stage of delaying time to progression versus the toxicities. Over the next few years, we'll also ascertain whether there is a survival benefit. And for patients where I wish to recommend docetaxel, I'd give docetaxel, complete the 6 cycles, and then as we did in the trial, patients will get Abiraterone plus Niraparib. I don't think we need to dynamically assess HRR status. This appears well set. It can be ascertained through the diagnostic sample. In fact, that's what we use in CRPC. But dynamic blood tests are certainly could have a role. So in combination with PSA, imaging is not helpful, and that's why we really need additional tests. You mentioned ctDNA. The ctDNA drops in the majority of patients, becomes undetectable. Whether it reemerges earlier than biochemical or radiological progression is uncertain. And the level of decline has been primarily reported in unselected patients. So whether the behavior is different in a population with a BRCA alteration or an HRR alteration is unknown. Because levels are so low, there has not been extensive ctDNA testing in the Amplitude trial. And really more work is going to be needed to understand the potential utility of ctDNA for this disease state.